So my name is Lauren Walter. I'm an associate professor and assistant APD at the University of Alabama at Birmingham, and I am going to, along with Dr. Allison McGregor today, give this talk. Allison is an associate professor at the Warren Alpert Medical School of Brown University and co-founder and director of the Division of Sex and Gender and Emergency Medicine at Brown University's Department of Emergency Medicine, as well as author of the recent book, Sex Matters. So we are both members of the SAM, Sex and Gender and Emergency Medicine Interest Group, and have been active in sex and gender-based medicine advocacy, education, and research for several years. And just to set a couple of quick definitions before we begin our talk. Anytime we're talking about sex and gender-based medicine, or when we refer to sex, we're specifically referring to the biologic construct of sex, so XX, XY, or some combination, intersex combination thereof. And when we're talking about gender, we're talking about the sociocultural construct of gender, which exists on a non-binary spectrum. So just to kind of set the stage as we dive into our talk today on sex, gender, and the opioid epidemic, crucial implications for acute care. So Allison, I'll let you take it away.
Great. Wonderful. So we set out the objectives to basically review the current literature using the sex and gender lens. So what are, what are the epidemiologic trends and projections when you look at it through the sex and gender lens? How does someone's sex and or gender contribute to drug use or misuse? What are important factors about sex and gender that can help with treatment? So including medication or behavioral interventions. And then really, how can you use what we have shown you to deliver more precise care for both men and women? We are emergency medicine clinicians or aspiring to be. So let's look at this in the way that we work clinically. So first, the case. So you have Valerie, and she is a 34-year-old cis female, which means that her biological sex is XX, her chromosomal complement. She is female, and her current gender identity is woman. And she presents complaining of diffuse body aches, nausea, vomiting, malaise. So you check out the EMR, and she does have a lot of various complaints and lots of different visits for different reasons surrounding some pain. And she has had urine screens that are positive for oxycodone and heroin in the past. And so she reports that she last used about 12 hours ago, and she's not feeling well. She feels like she's withdrawing and she wants rehab. Then you have Joseph, who was a 26-year-old cis male. And this means that his biological construct is XY. He is a male. And his current gender identity is that of a man. And he presents from the ambulance after a heroin overdose. He got Narcan en route, and now he's awake and alert. And most of the time, they want to go right away. You review the EMR, and he really hasn't been here, and you start to talk to him, and he mostly has been using heroin recreationally with his friends. He doesn't really have lots of depression or SI, but because of COVID, he's had been more isolated, and so he started using it alone, and he was kind of scared that someone actually noticed and called EMS, and he is now with you. So those are some very typical cases that we see. And if you look at the overall trends from the National Institutes of Drug Abuse, you can see that we're, of course, increasing in the amount of drug overdose deaths. 2010, we had about 22,000, and you can start to see when fentanyl really hit the world. And 2019, just before COVID-19, we were about 50,000. And when you look at this through the sex and gender lens, you can see that men definitely have more drug overdose deaths than women, but it's been consistent that women remain a third of those involved. So, it's interesting, but it's also scary that it's increasing in both sexes. So then we had COVID, and what we've seen is a huge surge in use. and deaths. And so let's think about that. What has this pandemic done to contribute to this? And there's a lot of border restrictions. The supply chain has been shortened, right? So what happens is now the purity decreases because people are altering their drugs to make sure that it gets around. It's also increasing the cost because of supply and demand. Not only that, people are using whatever they can get their hands on. So if they weren't used to doing it intravenously, now more people are using it that way. More people are adding other substances like alcohol and benzodiazepines. And the unemployment rate has also skyrocketed, and mostly to those who are, lower socioeconomic class. They've just lost their jobs. And so they're increasing use based on either depression or some people are being forced to get involved in the trafficking just to, get paid to be able to survive. And of course, at the same time, access to healthcare is down. Support groups have been down, if at all, during the severe part of the pandemic. And a lot of these patients have some immune deficiencies related to their lifestyle, and so this has really been a negative consequence. Now, what we do know is that substance use disorders are definitely related to the risk of suicide. So if someone has a substance use disorder, they are more likely to try to commit suicide, and they are more likely to be successful at doing so. So, suicide in the US is the 10th leading cause of death, which I think is really horrible because it's something that seems so preventable with good mental health. This is a great illustration, this article by Lynch and et al. Colleagues. And what they did was they wanted to look at the risk of suicide by substance use. And so what they did was they hypothesized that the more additive uses that someone is doing, the more likely they are to try to attempt suicide. And so what they did was they looked at men and it's a case control study. So they had enrolled men that had varying amounts of additive alcohol, drugs, or tobacco, and they compared it to men that didn't, so case control. And they tried to see if the additive effect increases the risk. But what they also did was they disaggregated their data by sex, and then they separately analyzed the same construct, but with females. So they had females that had substance use, and then females without. And so this is called sex-based analysis, sex disaggregating data. And this is exactly what we are headed towards. This is what we need to do for all of our studies, because there could be some important differences. And for this one, it did show that women were 2 times more likely to have the risk of suicide if they were both involved in alcohol, drugs, and tobacco. And so we don't think about this because we think men are more successful at committing suicide, but this is a great example of how to tailor our screening and prevention efforts when we illuminate something like this. And so we are learning a lot more because of our understanding of biological data. We are learning that based on your sex chromosomes, whether you have XX or XY, how that affects your cellular DNA and your metabolism and your brain influence of opiates, to sex hormones that has a major also play on inflammatory pathways, and how these things relate to the CNS pain pathway is pretty enlightening. And I'm going to use the example that has been coming out recently of, maybe men and women don't actually feel pain the same. So if you think about the pain pathway and you think about either tissue destruction or some thermal injury, what happens is that signal gets sent to your spinal cord from a peripheral nerve. And then it's passing that information on to a particular immune cell that will then send the signal up the CNS, the spinal cord, to the brainstem, to your cerebral cortex, so you can say, ouch, and then remove whatever it is that's causing pain. That's how we have always considered this. But there are these researchers at McGill University in Canada that were studying pain pathways in male mice. And what they found is that that this was in fact true. So if you look at it, they damaged the sciatic nerve and they made injury to it. And so this created a chronic inflammation, chronic pain, and it sent the signal to the microglial cells. And this is the pathway that we've all learned in medical school. That microglial cell then said, hey, go tell the brain that there's pain here. But what they also did, which was really remarkable, was they also looked at female mice, and they did the same thing, and they separated their data based on sex, and they injured the sciatic nerve. And what they found was that that signal went to a T cell and not a microglial cell. And that T cell was responsible for telling the brain that there's an ouch here. Now, how did they discover that? Well, they blocked the passage to the microglial cell and found that that gave pain relief to just the male mice, and the female mice were still in pain. So then they looked at, well, there must be a different pain pathway. And so then they looked at what are the effects of hormone therapy here. So then they blocked testosterone in the male mice and found that they then switched and used T cells. And then they found that female mice who were pregnant or lacked T cells switched and used microglial cells. So this is telling us how important it is that from the biological sex and the influence of hormones, our pathway to our brain stating pain is different. Why is this important? Because our pain medication has been designed to block the way that we thought that everybody, both men and women, exhibit pain and have pain responses. Okay, so now we're adding something to block a pathway that only works for one. And also now we're taking into account the differences between the pharmacokinetics of that particular pill as well. The chief bioengineer of the AstraZeneca drug company has said that they have already started to take this into consideration and are looking at sex-specific pain medication regimens that are specific to the body of whether you're a male or female. Plus, if we look at the effect of hormones, people who are undergoing gender transitions are taking exogenous hormones. What about this issue with pregnancy? What about with the menstrual cycle? How does this change even with all of that? And this is really important because in order to understand how men and women escalate to use and abuse has to do with where these where this effect is taking place. And so we really, you cannot assume that males and females or men and women are the same. We do know that the risk of forming addiction increases every day that you are on opiates. And so this is called a telescoping effect, and it's much more rapid in women. And so why? Well, I'm just showing you, like, it has to do with the genetics, the differences in body fat and pharmacokinetics and and these sex hormones. If we take these things into account, we can tailor our treatments. Then there's gender. That's really important too, right? So gender is how someone presents themselves in society. And so we know that women are more likely to seek care by the healthcare team. They're more likely to have more doctors. They're more likely to have overlapping prescriptions and lots of specialists. And so they might have lots of different prescriptions. They have a higher incidence of pain, chronic pain, painful conditions, fibromyalgia and autoimmune diseases. They're more likely to present with the expression of anxiety, which often gets confused with anxiety disorder. And women are more likely to be treated with benzodiazepines. And then they're susceptible to gender-based violence. So this leads to depression, anxiety, and lack of being able to seek health care. A little shout out to some SAM, SGEM interest group members. So Dr. Greenberg and Dr. Beauchamp has this great commentary that you can read that sort of looks through this And let's think of also the gender of the male. How does that affect? So Dr. Walter chose this illustration, and this is an Athenian Greek god who was the typical Stoic male, and he really sort of was known for saying, don't let your happiness be affected by the fear of being in pain. Don't be in fear of being in pain. Now, if you think about that and you think about today's world, a stoic male is considered a positive attribute in our culture, which maybe that should change. We should think about language that we use. This is a study that looked at clinical vignettes and changed the gender of the patient and changed the language from they have an opioid use disorder to they are an opiate addict. And what they found is that if it was a male and if it was termed opiate addict, that had the greatest negative effect. We're starting to change our language. We don't say alcoholic, we say alcohol use disorder. We don't say homeless person. We say someone who has housing insecurity, right? And I think that that's important for us to move forward with that. So Valerie, when we think about this, she was abused by her ex-husband, and this has led to a huge amount of stress for her life, taking care of her children, and that's what led to her getting involved and addicted. Where Joseph was getting high, and then with his friends, a lot of peer pressure there, and so he just kind of escalated to something that works faster and cheaper. So our motivations differ whether you are men or women. So I think that's important for us to keep in mind so that we can really target these interventions in a way that makes sense for the patient that we're caring for. And I will, so Dr. Walter's going to take over.
Great, thank you, Allison. So opioid use disorder treatment. So we've given a little bit of epidemiologic background, kind of pathology and pathophysiology background. Now let's talk a little bit more about the treatment and the impact on acute and emergency care. So opioid use disorder treatments to date have really focused largely on a kind of a one-size-fits-all mentality that doesn't really appropriately address the differences that Allison just described. Next slide, please. So a quick case update, just to kind of add a little bit more to both Valerie and Joseph's history. So Valerie was referred for substance treatment services actually twice in the past, but she was unable to attend either. And she's never been offered medications for opioid use disorder for treatment. And then Joseph, next slide, he admits to one previous overdose that required paramedic resuscitation, but he refused transport to the ED after he was resuscitated. And he hasn't been offered treatment either. And what that highlights both in Valerie and Joseph's scenario is that the vast majority of all patients with opioid use disorder are untreated. Only about 1 or 2 in 10 actually receive treatment. And if we compare that to other chronic disease processes, which opioid use disorder is a chronic disease process, but if we compare it to hypertension, diabetes, COPD, any other chronic disease process, this really highlights the treatment disparity that's experienced in opioid use disorder, both for men and women. Women, however, are less likely than men to be treated for opioid use disorder. In addition, women who are referred to inpatient treatment programs are less likely to engage in these programs than men. And women who do engage, they typically enter substance use disorder treatment with more severe medical, behavioral, psychological, and social problems, whereas men typically have more legal and alcohol-related issues. So when they are offered and access treatment, men and women are accessing and engaging treatment at different rates and with different comorbid profiles. Next slide. So gender-specific factors, including childcare, interpersonal violence, as Allison mentioned, financial vulnerability, and pregnancy have been identified as barriers to treatment for women and reasons why they may not consistently engage in treatment, even if they're referred. To this point, women have been shown to be more likely to stay in treatment longer if they have the support system in place to continue their role as a caregiver. So childcare is available. There's some employment flexibility that allows them to still be a breadwinner for their family. When they're able to engage in treatment, women who maintain treatment usually have similar outcomes as their male counterparts. Gender-specific barriers limiting initial engagement may limit those first steps and maintenance in treatment, however. So next slide. So buprenorphine, as you're probably all aware, is a medication used in the treatment of opioid dependence. Noted success across numerous clinical trials, including those which have examined ED-initiated buprenorphine. Buprenorphine is thought to be equally efficacious between women and men. However, women have been demonstrated to be more susceptible to craving symptoms than men during the maintenance phase of opioid abuse, which may translate to higher maintenance doses of buprenorphine treatment, which are needed, particularly during the initiation of buprenorphine, usually the first 7 to 10 days. Or they might need some more additional symptomatic support of these withdrawal symptoms during buprenorphine initiation as compared to men. So, next slide. So this was a 2018 study that appeared in the American Journal of Drug and Alcohol Abuse. The participants were 347 opioid-dependent men and 160 opioid-dependent women who were seeking outpatient treatment. They were randomized to either a 7-day or a 28-day buprenorphine tapering group, and they were followed over a 4-week time frame. And they collected urine drug screens over that time frame to monitor for illicit opioid use. So both women and men in the 7-day taper arm were significantly more likely than those in the 28-day taper arm to submit an opioid positive urine, indicating illicit drug use while on treatment. Women were more likely than men to use illicit opioids during the course of the trial, and comorbid medical issues were positively related to submitting an opioid positive sample during treatment for women, but not men. So this demonstrates the previous point that women may require either higher doses of buprenorphine and/or they might need additional symptomatic support of withdrawal symptoms during initiation to avoid craving symptoms and subsequent illicit opioid reuse. It also demonstrates what predicts reuse during treatment in women, specifically medical comorbidities, which demonstrates an additional burden and potential unmet need in women with opioid use disorder. Next slide. This was a 2019 systematic review that was published in the American Journal on Addiction that assessed sex-based differences in treatment outcomes for patients with OUD. They yielded 31 original research articles, which they included, and several important trends emerged, which the authors listed, some of which we've mentioned and will be and are reiterated. But one, women are more likely than men to present to treatment with co-occurring mental health conditions such as depression. 2, women are more likely to exhibit rapid progression of OUD, so that telescoping that Allison mentioned, and higher withdrawal scores upon treatment presentation, suggesting that they don't seek treatment until their physical dependence is more severe. And 3, women might respond particularly well to buprenorphine maintenance, as opposed to men who appear to do equally well with either buprenorphine or methadone. So again, suggesting that the way men and women present prior to treatment may be different. And in this instance, that buprenorphine in particular, while good for both, may be particularly effective in women for longer-term OUD treatment. So, next slide. Anytime we give a talk on sex and gender differences, always have to include the special population of pregnant women, and the treatment of drug addiction and pregnancy is a major consideration due to the epidemiology of dependence in women overlapping significantly with women in their childbearing years. So both methadone and buprenorphine are FDA pregnancy category class C, primarily due to insufficient data regarding their use during pregnancy. Of course, all opioids cross the placental barrier, and prolonged use of opioids during pregnancy results in adverse obstetric and fetal outcomes, including neonatal abstinence syndrome. Subutex, however, which is buprenorphine without the naloxone, can be used in gravid mothers, and depending on where you practice, that may be ED initiated or in context of addiction medicine services. So, next slide. So if providers can't meet the unique needs of men and women's clinical characteristics, it stands to reason they'll be less successful in treating opioid use disorders. So how does this translate currently for those of us practicing in the acute care realm? Well, I've got some quick tips for you as we kind of wrap this up. So next slide. So the first tip is just opioid stewardship, good opioid stewardship. So safe and effective administration of opioid therapy is recognized as requiring initial assessment of the risks and a patient's potential for developing opioid use disorder. So if you find yourself in the situation where you're considering writing for an opioid prescription, there are multiple resources and tools out there, and this is an example of one. It's the ORT, or the Opioid Risk Tool, developed by Weber in 2005, Webster, that you can utilize, but there are multiple out there. And even if you're not using a tool, at least consider a shared medical decision-making conversation. And just a reminder that considering the assessment of OUD risk and to be aware that everyone is unique in their background and their presence of predisposing characteristics which might place them at risk for opioid use disorder. So again, just good opioid stewardship. Next slide. And then number 2, screening for substance use and misuse should be universal. This is a single substance abuse question that's validated. It's a validated primary screening tool recommended by both NIDA and SAMHSA, and a positive response is equal to a positive screen. So this is something easy that we can incorporate into everyday practice. Next slide. And then of course, if you get a positive screen, being able to take that the next steps. So being able to conduct or engage in a spurt with your patient. So not every patient affected with OUD is going to self-identify, which is why the screening is so important. Consider in particular women presenting with concurrent depression, anxiety, or other mental health concerns, or even repeat visits with apparent somatic physical complaints without identified pathology. That should send up some flags and get some bells ringing for you. So taking 2, maybe 5 minutes to engage in a spurt with a patient with a positive screen or other red flags might be the first step toward OUD recognition and ultimately treatment. Next slide. Yeah, and this is a picture of a readiness ruler. Patients are used to rating their pain on a 0 through 10 scale. And so this is a familiar concept to them. So after you've engaged in your 2 to 5 minutes of your spurt, maybe asking them, okay, so how are you feeling today on a scale of 10? You're ready to go to rehab right now. 0, you're done talking with me. How willing do you think you would be to consider changing your opioid use habits or seeking help for this? And most patients, unless that's why they're coming to the ED, probably aren't going to be at a 10, but most patients aren't going to be at a 0 either. And so this offers you an opportunity and an in to provide them with further insight, further resources, and potentially a referral to treatment. Okay, next slide. Third tip is to prescribe buprenorphine. It works, and with the recent relaxation of the Department of HHS rules, the training has been waived, and so it's a lot easier for folks to get their X waiver. So if you don't already have that, please do so and start doing this in the ED. Next slide. Harm reduction, so Narcan kits, even if if they don't want the buprenorphine, making sure that you're giving them all the harm reduction tools that they need, potentially even fentanyl strips and needle exchange if that's available in your area. I apologize, I've been given the wrap it up thing. And then number 5, assessing social risk and need and considering how that might impact your treatment plan. And considering specifically in this regard, gender specific issues which might be present. So childcare issues, legal issues, and engaging your social work resources that you have to make sure you're meeting the needs of this population specifically. And so finally, in a case wrap up, so Valley, she was cleared medically. She was given buprenorphine. A social worker helped her arrange MAT follow-up that worked with her work schedule. She was given a Narcan kit, a peer contact, and underwent universal screening for hepatitis C and HIV. And Joseph decided he was not ready to engage in definitive treatment, but he did accept a Narcan kit and underwent the same universal screening. So finally, as we wrap up, if you're doing research, please ask the sex and gender specific questions in your study design or when you're just considering or interpreting your data. It's clear that a sex and gender approach is increasingly necessary to understand and approach the opioid epidemic successfully. EM docs are in a particularly unique position as they are oftentimes the patient's first and sometimes only contact with a healthcare provider. And ED interventions can enable patients to receive treatment for OUD that's successful. And so that our role and our resources and linkage can have a significant impact for both men and women. So thank you for your time.